Ladies and gentlemen, welcome to IVF Around the World. We are here all the way from the University of Kent in Canterbury and all the way from Dubai. Shadi Khalil, say hello.
Hello.
Fantastic. So we are very, very excited to bring you on board today. Hello to Alessia. Hello to Bruno. Hello to Ekaterina. Hello to Garda, to Hugo, to Jency, to Lucia, to Pedro. Hello to Sangeeta, to Sebastian, and to Tiara and Zainab. It is fantastic to have you all here. As always, we've got an exciting program to tell you all about, and I can tell you that there are, oh crikey, 62 of you here and joining us already, and we hope to make it back to 100. It is coming to you from the University of Kent, from the IVF company, all the way in Dubai, and it's fantastic. So who are we going to have with you today? We are going to have Dr. Sami Almusawa, who graduated from medical school in Jordan in 2003. He worked in Jeddah, Saudi Arabia for 3 years before moving to the UK in 2006 to work on general obs and gynae, and subsequently became a member of the Royal College of Obstetricians and Gynaecologists. In 2010, he started working exclusively in infertility at IVF Hammersmith Hospital, and then went on to work at ARGC for 8 years with Mohamed Taranissi. He's currently working at Salisbury's NHS Trust. So he is going to tell us about IVF from start to finish. And would you believe he's going to do that in 40 minutes. Wow. So I'm very, very impressed. So ladies and gentlemen, we very much would like you to post your questions in the question bar. I will try and get through as many of them as I can. But without further ado, it gives me great pleasure to introduce Sami Almusawa, who will tell you about IVF from start to finish. Sami, over to you.
Thank you very much, Professor Darren. So yes, the talk today is about IVF. And I'm hoping to try and cover an overview of the clinical side of IVF, but also just to try and make sure that we talk about things which are coming up in IVF for the future, possible treatments which may or may not improve IVF in the future, and we'll just go through that towards the end of my presentation. So we're talking about IVF and also infertility. Now, infertility is a very common problem. The incidence is increasing. So most couples do conceive when they try naturally within 12 months, but there is a rising incidence of couples who are needing fertility treatment, who seek fertility help. We're not sure why. Is it to do with things like the pollution? Is it to do with the environment? Is it to do with stress? Is it to do with maybe radiation, radio frequencies? We've got now Wi-Fi everywhere in our homes, in our offices, in the streets. 5G, things like that. Do they have an impact? We don't know, but we do know that in developed areas, there is an increasing incidence of infertility. One obvious cause in developing areas that I experienced very much when I was working in London is that women are choosing to delay getting pregnant until they are older to focus on their careers. And of course, we all know that as a woman gets older, the chances for her to achieve a pregnancy will be much lower. It does cause a lot of anxiety, stress, mental health problems, relationship strains. And in the UK here, NHS treatment is available, but not for everyone. There are certain criteria which couples need to fulfill to be able to achieve treatment under the NHS. It's not a very fair system, in my opinion. And since I started doing IVF about 11 years ago, it's been pretty much the same in that we call it a postcode lottery. So it depends on where you live as to whether or not you achieve the criteria, fulfill the criteria to qualify for treatment. In some areas you have to be under 35, some areas you have to be over 30, some areas you can be up to 42 years, some areas you can have had a child with a previous relationship, etc., etc. So it does vary a lot from depending on where you live. Primary infertility or subfertility is where there has not been any pregnancy before. Secondary, where there's been a pregnancy, a miscarriage, or there's been a child, and then subsequently it's been difficult for the couple to get pregnant again. Now, the causes for infertility are about 30% male, 30% female, 25% unexplained, and then the combination is the remaining 10% and 5% is other. So about a third is male, a third is female. Unexplained is also quite common. Now, unexplained is where a couple have been trying for at least a year, if not two, with frequent intercourse and not achieved a pregnancy in that time. All the tests that have been done have come back showing no problems. And then quite often in the clinics, the patients ask us, well, I've been trying for 3 or 4 years. The tests are not saying that anything is wrong. Why am I not getting pregnant? Well, it doesn't mean that there isn't a problem. It's just that we haven't been able to pinpoint the exact problem with current testing, which is available. And towards the end of my presentation, I'm going to talk about things which are upcoming, which might help us in the future to improve the chances for these people and to understand better things which are involved with conception that we don't really appreciate at the current time. So when we see patients in the clinics, in the fertility clinics, we do take a history just to try and understand what potential problems could be. We need to know the patient's age, both male and female. Of course, the female, it will have a more impact. If one of the partners have had children before, if the woman has gotten pregnant before, of course, that's always a good sign. But bodies don't always stay the same, and something may have changed, which has now made it more difficult. And this is what we need to focus on trying to identify. Because, of course, if you do identify a problem, then you can focus the treatment and improve the chances for the treatment to be successful. Now, if a woman does have a regular menstrual cycle, then this will tell you pretty much for sure that she is ovulating. Unless she's on, combined oral contraceptives or exogenous hormones, there's no other reason why women have fairly regular cycles, which you can predict within 1 or 2 days. Frequency of intercourse is very important, so we recommend couples to have intercourse every 2 or 3 days. That way you will get the best quality sperm, but also there will be sperm there, hopefully, when she does ovulate. It's not always easy to pinpoint the ovulation. Some people do it by dates or ovulation sticks, but none of these are 100% reliable. And therefore, I recommend my patients to have frequent intercourse every 2 or 3 days from when they finish their period until the next period comes, to make sure that there is sperm waiting for the egg once the ovulation happens. We also like to know if they've had previous treatments, because we can learn from past experience. Even if it's been in another clinic, we can know, have they had fertilization, how many eggs does the woman produce, has there been difficulties with the sperm, how have her embryos been, what were the embryo quality, things like that we can look at and then try and identify perhaps where we can improve the treatment to give better chance. Important thing to consider, is this woman fit for a pregnancy? Sometimes there are medical conditions which may mean that this woman shouldn't get pregnant because it will be a risk for her health, and we need to seek the help of her medical doctors to make sure that we are actually doing the right thing by helping her to get pregnant. Any drugs that the patient's on, history of infections can also affect things, and of course smoking and alcohol, and if they are taking alcohol or smoking, we recommend strongly that they stop. Quite often, the male infertility is not investigated until much later. I've experienced this a lot in the Middle East, where we would see the female partner and do testing, and then she would expect us to start some treatment without even seeing the male. I was a bit surprised when I came to the UK, and I also saw that here as well. And that quite often the man would say, oh, just get the woman tested first, and then if you don't find anything you really need me to come, then I'll come and do my semen analysis, which isn't the way it should be. The semen analysis is pretty much sufficient for us to get an idea, is there a problem or not. If the semen analysis is normal, then we actually don't need to worry about this man so much. Most likely it will be fine for further treatment. Whereas for the woman, you need to do lots of tests, you need to do hormones, you need to ultrasound scan. So actually it's a much simpler thing to test the man than to test a woman, because she will need to time tests and multiple visits to the clinic quite often. Now, what is the commonest cause of suboptimal semen analysis? Well, we call it idiopathic, or we can't really explain it. We don't know why. Sperm is getting worse with passing years. So if you look at studies which compare semen analysis from the 70s and 80s to current day semen analysis in many countries around the world, especially developing countries, there is a reduction in the sperm quality. Exactly why that's happening, we don't know. It could be, like I said, to do with the pollution or the lifestyle, diet, stress, things like that. But we don't understand it completely. And it is a bit of a worry, because if this trend continues, we may be in 30, 40, 50 years, or whoever knows how long, in a position where most men have a sort of suboptimal sperm and will need fertility treatments. Hopefully that doesn't happen, but that's something just to think about. So there could be other causes that we can pick up from the history. Cryptorchidism, I've written there, which is where there is undescended testes. Now, in most countries, boys, when they're born, they will be checked for this, they will be examined. to make sure the testes are down in the scrotum, and if they aren't, then they'll be re-examined at the age of 1 year, and then if they still haven't come down, the boy will undergo an operation to bring down the testes, either one or both, depending. Because when the testes is inside the body, it's not at the wrong temperature, and it causes problems, then it damages the testes. It will mean that even if you bring it down at an older age, there's likelihood of the sperm production being affected. And also, if it's not picked up at all, then this testes inside the body can change and undergo cancerous changes, which can be risky for this patient's health. Genetic problems, where there are abnormal amounts of chromosomes, for example, Klinefelter syndrome, or different genetic problems can lead to suboptimal sperm, cystic fibrosis, etc. Previous infections, very famous one is mumps. It's quite rare to get mumps as an adult, but if it does happen to a man, then quite often it's accompanied by orchitis, which is inflammation of the testes, and that can also then lead to subsequent reduction in sperm production. Erectile disorders are very common, and nowadays we have quite good treatments for it in the form of tablets like Viagra or Cialis, and also surgical treatments. So that's something which may need to be addressed with the health urologist, andrologist, and problems with ejaculation as well. Biggest issue with female subfertility is age. As the woman gets older, the quality and more importantly, the quantity and more importantly, the quality of the eggs will decline. And it's mainly the chromosomes that we worry about, because a woman doesn't produce eggs. It's not like sperm. She'll be born with her eggs. Even before she was born, she would have her eggs inside her ovary. And these eggs, with time, especially over the age of 35 years, they will start to become, the eggs will start to degrade, and there will be problems with the genetic material we call aneuploidy, where there's not quite the right number of chromosomes. And this will lead to a poor quality embryo. Most likely this embryo won't implant, she won't get pregnant, but if she does get pregnant, then the likelihood is she'll miscarry in the first 12 weeks. There may be a problem with ovulation with this woman. So the commonest cause for this would be something called PCOS, Polycystic Ovarian Syndrome, and it's quite a complex disease as to why it happens, but it's extremely common. In some areas of the world, 10 to 15% of women have this, and it will cause irregular cycles most of the time. Some women won't even ovulate at all. And it can be helped with medication to try and stimulate the ovary to produce the eggs. Uterine factors, if there's a problem with the shape of the uterus, if there is a big fibroid inside the uterus, big polyp, or sometimes, rarely, there can be genetic issues which mean that the woman hasn't even got a uterus, in which case you'll need to think about surrogacy. Problem with ovarian reserve, so most women will have a decline in the ovarian reserve starting from the age of 35 years, but sometimes even very young women can have a very low egg reserve, sometimes so low that they can go into an early menopause. We call it premature ovarian failure. And for these women, it may be impossible to stimulate the eggs, and the only option would be to think about something like egg donation if she is happy to do that. Problems with sexual intercourse can also affect women. The biggest issue with this is something called vaginismus, where during intercourse the vagina will go into spasm and make it difficult for the man to achieve penetration. And it's quite a difficult thing to overcome. The treatment is psychosexual, using vaginal dilators, and actually success with this is quite poor. And then hypothalamic, which is a hormonal problem, and I'll go through that a little bit later in the presentation as to what the hypothalamus is and what the role of it is in terms of fertility. When we see the patient in the clinic, sometimes they do look a little bit, I've written there, funny looking, maybe not the most PC term, but they look a bit abnormal. Sometimes it does indicate to us that it could be a chromosome problem, things like Turner syndrome, Klinefelter syndrome. Sometimes you do get suspicion just by how the patient looks, and that might promote us to do a chromosome karyotype test to check the genetics early on in their treatment rather than waiting till later on. You can also quite often detect high anxiety levels, relationship problems. Most of the patients that we see will be quite stressed, but especially if the couple have gone through multiple attempts at IVF which have failed, or multiple miscarriages, it can really lead to very high anxiety levels. And for these patients, really counselling is important to help them overcome this. Of course, what they want is to have a baby, so if you do manage to help them with that, then that will solve most of these stressful issues, but that's not always something we can achieve, of course. BMI, body mass index. So if the woman is very obese, not only does that cause problems for when she is pregnant, high risk of diabetes, hypertension, other complications in pregnancy. But there is evidence to show that it makes them less likely to succeed with IVF and makes the IVF a little bit more difficult and risky. Features of polycystic ovarian syndrome, so things like hirsutism, where there's excess of facial hair, acne, changes in their pubic hair, things like that you can see on examination. Secondary sexual characteristics, if they have no periods especially, and some women have, for example, no hair in their armpits and the axilla or pubic hair, it may make us think about things like testicular feminization or other chromosome problems where they're not actually producing hormones. Hypogonadotropic hypogonadism, for example, as well. And for the man, you can do a testicular examination just to make sure that the test is of the right size, consistency. You can check for what we call varicocele, which is varicose veins in the testes, and also you can see, so you can feel something called the vas deferens, which is a tube that carries the sperm out of the testes. So this is just a picture of something called an orchidometer, which we can use to measure the volume or get an estimate of the volume of the testes. And you can see the orange here. This is the normal range. If it's too small, that's not good. It may suggest things like Klinefelter syndrome, or if there's been testes within the body or something like that. But also too big, which is the red area, that's not good either, because that can sometimes be associated with something called fragile egg syndrome. They have larger testes, but their testes are actually not very effective, and it's not really a good thing to have. So investigations for the man, we just need the initially semen analysis, and then if that is abnormal, if it's very poor semen analysis, we may want to do chromosome testing, hormone testing, things like that. But most of the time, the sperm isn't sufficiently poor that we need to do that. So that's quite often where it ends for the man. For the woman, we do a set of hormone tests, usually in the beginning of the period, day 1 to 3, we check the FSH, LH, estradiol. Very important to check estradiol. Some clinics, they don't do this. They will just check the FSH and LH. And if you don't check the estradiol, that may be misleading, because if the estradiol is very high, there's a negative feedback, which I'll talk about a little bit later, which may mean that you are masking the FSH and the FSH appears lower than it really is. And if the FSH is low, that's good, but if the FSH is high, that means there's a low egg reserve. You're going to need to start with a higher dose of medication. It may actually not even be feasible to start IVF. So it's important to get this full profile to understand fully what your patient is in front of you. You could also check something called AMH, anti-Müllerian hormone, which will also give another idea about the egg reserve. And we do an ultrasound scan to look for something called antral follicle count. Antral follicles are the small follicles in the ovaries, and again, a higher number indicates a good egg reserve, a lower number is a lower egg reserve. To check for ovulation, we do a mid-luteal progesterone. So the menstrual cycle is divided into two halves. The first half is the follicular phase, and then the second half, luteal phase. Follicular is when the follicle is growing on the ovary. Luteal is after the ovulation. Mid-luteal, so around day 21 in a woman who's having a 28-day cycle, or you may have to adjust that according to the length of her cycle. We can check the progesterone, and if that's quite high, then that confirms ovulation. To check the fallopian tubes, we would do a dye test, either with X-ray, and that's called HSG, hysterosalpingogram, or with ultrasound, and that's called hycosi. And you can see if there's any blockage within the tubes. It's not 100% accurate, because sometimes there can be spasm within the tubes, and a more definitive way is to do a laparoscopy, which is a telescope to look inside the abdomen, and then inject dye from below into the tubes, and you can see the dye flowing through the tubes. Sometimes we do extra tests, so I've written them in blue here, things like further hormones. Sometimes if someone's having very irregular cycles, you would add in a prolactin or thyroid function test. And we may do laparoscopy, like I mentioned before, to check the fallopian tubes. It may show the pathology. Hysteroscopy is a telescope to look inside the womb, and that can help you to pick up abnormalities in the shape of the womb. It can pick up polyps, fibroids, but also sometimes you can use the hysteroscope to cut away and treat the fibroid or polyp and improve the condition of the uterine cavity to make it easier for her to get pregnant. Sometimes a woman may have scarring inside the womb. We can also cut that away with hysteroscope, and that's more common if she's had miscarriages. An evacuation of the miscarriage products can also cause scarring sometimes, or if there's been an infection within the womb. So treatment treatment options. First step is lifestyle modification. We ask the woman to lose weight if she's overweight, and the man. And we ask them both to take multivitamins, not to smoke if they're smoking, alcohol reduction, caffeine reduction. These things are quite simple and they should be the initial step taken. We advise them about frequency of intercourse. I mentioned that earlier. Every 2 or 3 days is the ideal. If a woman is not ovulating, then we can use drugs to induce ovulation. The famous drug is clomiphene or Clomid, and that's a selective estrogen receptor modulator. So it tricks the brain to thinking by blocking the estrogen receptors in the brain. It makes the brain think that there's not enough estrogen. The brain will then produce more of the FSH hormone, which is follicle stimulating hormone, and that will push the ovary to produce the follicle. It's not 100% successful with ladies with polycystic ovarian syndrome. It's about 50% roughly that will succeed with this. So in order to try and improve the success, we can give a drug called metformin, which is, some of you may recognize as a diabetic drug, anti-diabetic. Metformin works on insulin resistance, which is a common thing with PCOS, and that will link in with her hormone profile and help improve the response with the clomiphene, or if you're using injections, or even you can use it with IVF treatment. Another treatment sometimes used as a last step, especially if a couple is not going for IVF and looking to try and get pregnant naturally, and she is suffering with infrequent cycles, we can do something called ovarian drilling, where this is done with laparoscopy. So we put a telescope inside the tummy, and then we have like a hot probe which will be inserted into the ovary in a specific way to reduce the amount of tissue within the ovary, and that can achieve in some women regular cycles, which will then enable her to get pregnant. It's not, again, a very highly successful treatment, and definitely not a first-line treatment either. Hysteroscopic treatment, I mentioned to you before that we can use the hysteroscope as well to cut away at fibroids or scarring or polyps. And laparoscopic treatment, if there are very swollen fallopian tubes, we call it hydrosalpinx, where there's fluid within the tube. This fluid can leak back into the uterine cavity and cause the environment within the womb to be unfavorable for the embryo when it goes back inside. And therefore, what we can do is either remove the whole tube, because it's a damaged tube, it's not going to help her to get pregnant anyway naturally, and it will improve IVF success if we do that beforehand. There's a lot of evidence to show this. Or we can put metal clips on the end of the tube to prevent this fluid leaking back inside the womb. Some women are very attached to their female organs, and even if you mention them removing the tube, they feel very against it. Therefore, the clip sometimes is a way to do it without actually removing any tissue from it. IUI, intrauterine insemination. This is a treatment which is good for couples who are having problems with intercourse. So when they are not able to have sex naturally and achieve full ejaculation, etc., then we can take the sperm from the man, we spin it up to concentrate it, and then we inject it with a fine catheter inside the womb in a similar way that we do the embryo transfer at the right time. So when she's about to ovulate, or sometimes we use drugs just to prepare for this, in the hope that this sperm would then swim up and meet with the egg and fertilize within her body. It's not the best treatment for unexplained infertility when they have been trying for 1 or 2 years with frequent intercourse and they haven't achieved pregnancy that way. Then I don't usually recommend it, because it's not really a likely treatment to work. If they're going to have frequent intercourse, it doesn't really add much to what they've been doing already. Of course, then IVF and ICSI. ICSI is where usually we do it for where the sperm is poor in quality, and we can inject the sperm inside the egg. And I'll talk about these, of course, in a bit more detail. So what kind of patient looks for IVF or asks for IVF? Well, if there's a clear problem that would make getting pregnant difficult or impossible, if she has got blocked fallopian tubes, for example, if we've removed the tubes, if the sperm is extremely poor, then the likelihood of achieving a pregnancy naturally is almost zero, or very little. And IVF may bypass the tubes, or we may be able to do ICSI to improve the chance of fertilization. Unexplained infertility. So even when we don't know what the problem is, by doing IVF, quite often we bypass many steps involved in conception that we don't understand, and we can still get good success rates with IVF, because even though we don't know what the problem is, we're able to jump ahead. And sometimes we can do IVF for patients who are looking to select embryos. Select embryos which are genetically healthy, for example. If they've had multiple miscarriages, we can screen the embryos and see which embryos have normal genetics and use those embryos in the treatment. Or some couples, they have inherited genetic diseases. We can again screen the embryos and try and find those which are genetically normal and transfer those back to avoid disease. Steps involved in IVF. So first step is to stimulate the ovaries to produce the eggs. Then we collect the eggs from the body, fertilize the eggs with the sperm, transfer the embryo back inside the womb, and then we wait to find out if she's pregnant. During stimulation, we would give the drugs to push the ovaries to produce lots of follicles, and you can see that as the days of stimulation go, especially in the second half, there is an accelerated increase in the estrogen level, which means that each follicle will produce some estrogen, and that will then be an indicator as to how this woman is responding. We also need to do ultrasound scans to see how this woman is responding as well. Now, IVF protocols, the common protocols that are used are either agonist or antagonist. Agonist is where we give a blocking agent, GnRH, which would block the receptors on the hypothalamus from the pituitary. The receptors would be blocked initially. The agonist, stimulates the receptors initially, and then it will eventually saturate these receptors and cause a blocking effect. Antagonist is the one that will block immediately, and that works straight away. So usually if we talk about long or short protocols, the long protocol would use the agonist because you need a bit more time to overcome the initial stimulation and then get that down regulation, we call it, where the ovary is suppressed. And then the antagonist, it works very quickly, so we can give that during the stimulation phase. Now, the antagonist is a protocol that we tend to use for women who have lower egg reserve, because sometimes if we switch off the ovaries for too long, they don't wake up very quickly or they don't wake up at all. But also the antagonists, there is evidence to show that it can reduce the risk of hyperstimulation syndrome, which I'll talk about a little bit later as one of the complications of IVF. So it is depending on the patient that you would choose between these protocols, and it depends on the history and the blood tests and the scans that you've done already. Stimulation drugs, so we again would choose a dose depending on the history and the examination, and also the blood test that you've done. And if you've had IVF before, how they've responded previously to different drugs. Drugs that we use for IVF are injections. They are hormone injections. We can give FSH alone or FSH plus LH, and again, we can decide this based on blood tests. And these drugs come either in the recombinant form, synthetic form, which are made by bacteria, or you can get them from natural sources, so natural hormones from women or animals. They need monitoring, so along with the IVF injections, you'd start then doing blood tests and scans in a serial way to be able to observe how this woman is responding, and then you can adjust the dosage of medication according to how they're responding. You don't want to give too much, because too much, yes, you would probably get more eggs, but you may lead to overstimulation, hyperstimulation syndrome, where the woman gets unwell. And if you give too little, then she doesn't produce enough eggs, and you may have to cancel your treatment if she produces nothing at all, which is also a failed cycle. The last stage in the stimulation would be to trigger the maturation of the egg, and we give HCG typically, which will have an LH type effect. HCG you may know as the pregnancy hormone, and again it can be in the natural form or the recombinant. The dose of the HCG will again depend on the blood test and the history. Some clinics do just give a standard dose, but you can also tailor this dose to the patient that you have in front of you. If they've had previous failed fertilization or immature eggs, then you may want to increase the dose, but that can also increase the risk of premature ovulation and ovarian hyperstimulation. And if you've given an antagonist protocol, then you can use an agonist to give you that same effect to mature the egg. So this is just something that you should all know if you're interested in subfertility, reproductive medicine, is the hypothalamic pituitary ovarian axis. And similar one would exist for the man, for the testes. And the hypothalamus produces GnRH, gonadotropin releasing hormone. Gonadotropins are FSH and LH, and these will be released by the pituitary to stimulate. FSH stimulates the maturation. Sorry, FSH stimulates the ovary to produce the eggs and the follicles, whereas LH will induce the maturation, and that happens sort of in the latter half towards the ovulation time. Long protocol I mentioned usually would have the GnRH agonist, and most of the time we start it in the luteal phase, so around day 20, 21 of the cycle, depending on the woman's cycle, of course. They would start to take this GnRH agonist, which will have initially a stimulation effect, and later on it will suppress Now, a lot of people ask, why are you suppressing when you try and stimulate? It's because we want to have a controlled stimulation. We don't want this stimulation to get out of control. We don't want the hormones to, we don't want too much LH. We don't want too much estradiol. Too much LH and estradiol can actually cause damage to the egg quality, and too much estradiol also, if there's too much stimulation, you can lead to the hyperstimulation syndrome. So we do need to give something to suppress, and GnRH agonist is one of the first drugs that was used. It's cheaper than the antagonist, and it's still in widespread use. Like I said, for good responders, for younger patients, we tend to use this. The antagonist, quite often they call this the short protocol. It would be short because we don't need to start the antagonist until the woman has started a stimulation. We start usually with the period, whereas with the long, we started before the period. This one, we don't need to give anything until the period actually starts. And the antagonist will work within hours, whereas the GnRH agonist would need a few days to be effective. When we come to collect the eggs, we use an ultrasound machine to see where we're going, and then we pass the needle through the vagina into the ovary and aspirate the fluid into this tube with the embryologist there to decide if there's an egg or not, and then the eggs are then taken back to the lab for fertilization with the sperm. This is commonly done procedure under sedation. So most of the time we don't need a general anesthetic for this. The patient will just need some sedation to be resting. It's done 36 to 37 hours after the trigger injection, and that's to give enough time for this for the eggs to be mature, because if you collect immature eggs, yes, sometimes you can get them to mature, but especially in the laboratory, but especially if you're doing ICSI, you would like them to be mature so that you can do the ICSI straight away. We can use single channel needle where we just aspirate, or we can use double channel where we can also flush the follicle. If the egg doesn't come with the first aspiration, we can introduce some media into the follicle to flush it out, and that gives a better chance of picking up the eggs. And you need an embryologist there with you to identify and gather the eggs. Man will need to produce a semen sample, or sometimes there will be frozen sperm to use, especially if there has been surgical retrieval of the sperm. Now, the embryologist will then decide whether they're going to do IVF or ICSI. For IVF, we want to have good quality sperm, good previous fertilization, and probably a good number of eggs to make it worthwhile. With ICSI, we do this with frozen sperm or frozen eggs, or if the sperm has been extracted surgically from the testes or the epididymis. We also do it when we're planning to do genetic testing of the embryos, PGD or PGTA. The embryo transfer, typically 2 to 7 days after egg collection, 2 to 6 more commonly. We don't need any sedation for this, and it can be done either under ultrasound guidance with an abdominal ultrasound done by a nurse or another clinician to see the embryo transfer catheter going inside the womb, or you can do it through clinical touch. There isn't much evidence to show that one is better than the other. Some studies do show ultrasound guidance, but where I've worked before in ARGC, they don't use the ultrasound, and still they get very high results. So I'm not sure it makes much difference, but sometimes the patients do like to see the procedure on the screen, and they can see the flash of fluid which you inject inside the womb, and they quite enjoy that quite often. So the risks and side effects of IVF: nausea, bloating, tenderness. These are quite common side effects, especially as the ovaries get bigger. Hyperstimulation syndrome. This is something which can happen, especially as the ovaries are responding very well. If you have too much response, too many eggs, too many follicles, the ovaries can grow to a large size. There's fluid in the tummy, fluid in the chest. Sometimes even the patient needs to be admitted to hospital to be helped to recover from this. And this is caused by us, by clinicians, by giving too much of the medication. And this is why it's important to monitor the treatments, to tailor the treatment according to your patient, and not just do a blind treatment the same for everyone. Bleeding, infection, injury to bowel, bladder, blood vessels, these are risks from the egg collection procedure. There's a risk of multiple pregnancy. We try and reduce this in the UK. The HFEA, who govern the fertility treatments in this country, they try and encourage single embryo transfer for when there is going to be a good chance, rather than putting two like we did in the past. Nowadays, a lot of transfers are in the blastocyst stage, day 5 or 6 embryos, as opposed to day 2 or 3 embryos that were done previously. And if the embryo has reached day 5 or 6, then you tend to get a better understanding about the embryo. And if it seems to be a high-grade embryo, then if the woman is young and she's not had lots of failures before, it's suitable to put one embryo back and to try and reduce multiple pregnancy. But there's still a higher chance, even if they have one embryo back, that the embryo can split and they can still result in a multiple pregnancy. Miscarriage, this happens with natural pregnancy, of course. Ectopic pregnancy, Embryo can go into the fallopian tube or outside of the womb, and this is 3% with IVF, 1% with natural pregnancy. There's also a lot of emotional and psychological disruption due to IVF, especially when the cycle has failed or there's been repeat failures. Success rates very much linked to age. So done a little table here. The success rates do vary a lot by clinic. So some clinics do have higher success rate than others, and you can look on HFEA website to see results in the UK, or look at the clinic websites in different countries to see your clinic's results. But you can see from the table here that as you get to the older ages, 45 years, only small difference between clinics. And this is because the biggest factor at this stage is that it's going to be very hard for you to get a good quality egg. An embryo, in terms of the chromosomes, most of the eggs and embryos, even if they look okay under the microscope, are going to be genetically abnormal, which means the chance with IVF is very slim. So the younger age groups are really where you can try and tailor things and get a bigger difference in terms of success rates. When a woman is very much at 45 or beyond, it's very hard for her to get pregnant no matter what you do, because they're beyond your control, beyond your help. So just want to spend the last part of the presentation talking about things which are hopefully coming up in the future, which may or may not prove to be useful for us in terms of improving those success rates and getting the patients to be pregnant, because even when we've transferred good quality embryos, which look to be okay under the microscope, they don't always result in a pregnancy. Even when we've done genetic testing and we know that genetics are normal, we don't get 100% success rate. Perhaps it is to do with the fact that the genetic test is invasive currently, and it can weaken the embryo. Now, first one I've got is pinprick blood testing. Now, this is already available. It's not completely experimental. We use a pinprick blood test to evaluate hormones. It is used at the moment in some clinics in the UK for AMH, anti-Müllerian hormone. Problem with this, it's not very accurate compared to the blood test. So when I was working at my previous clinic at ARGC, we did trial pinprick testing for checking hormones like estradiol, progesterone, LH, to compare it with the proper blood test where you take a big sample. And unfortunately, the accuracy wasn't there that we could rely on it completely. So that was abandoned. But for AMH, you don't need it to be 100% accurate. It's a vague indicator. It's one part of the picture. You'll still combine the AMH result with antral follicle count, with also FSH and LH and estradiol levels to get a complete picture. And even if it's a few points here or there, it won't make such a big difference. And with the COVID problem that we have nowadays, and we're trying to limit patients coming into the clinic, some clinics are sending out testing kits to patients' home where they can just do a pinprick blood test, send the blood sample back in the post, and the lab will evaluate that and they'll give you a guide for the AMH. So some clinics are doing that at the moment. Hopefully in the future it will develop to the extent that it may replace blood tests, because this is one of the drawbacks of IVF, is especially in some clinics where daily blood tests are done or every other day. It is very unpleasant for the patient to have to go through this again and again, and pinprick may be an easier option. Non-invasive pre-implantation genetic testing using spent embryo media, cell-free DNA. This is something which is upcoming. Again, it's not quite as accurate as doing the invasive test where a needle is inserted into the embryo to remove some cells or a cell. It's not giving us quite the same accuracy that it will replace it just at the moment, but hopefully, I'm hoping that with time, if this does improve, this will be a really revolutionary step in IVF, which may be offered to all patients, because if we can know the genetics of the embryo, it will really help us in selecting. We have alternative tools at the moment, like the time lapse and just looking and grading embryos, but this doesn't always give you an accurate representation of the genetics. So this is something which is upcoming and hopefully in development and hopefully improve. And if you're interested in this, to know about this more, if you look at the YouTube channel for the IVF company, there is a webinar that they did a few weeks back on this topic that you can watch again. Artificial intelligence is something which is coming into our life on all aspects of life. And it's also something which will be introduced into fertility treatments. So for time-lapse photography, which is used to monitor embryos in a special chamber, which will take lots of photos of the embryo, And then this will mean that you can have a lot more information than just looking at set times of the embryo as to how the embryo is developing. At the moment, a lot of this is done by just embryologists and their own experience, and that will create a lot of variation, and depending on the experience of the embryologist as to which embryos are selected. There are some algorithms which are now out there which are being trialed to see if using a computer algorithm would make it more uniform and hopefully more accurate, and get better techniques to check the embryos and see which are the best to transfer. So this is something which is in development, and again, I feel that this is something which would probably be in use if it's proven to be useful. Similarly, algorithms which offer artificial intelligence to adjust IVF stimulation is something which is in development, where you put in the patient's age, the antral follicle count, the size of the follicles, blood tests, just put in all the information that you can, and the computer will tell you how much of the medication, which medication to use, and perhaps that will give a more uniform approach to give a better outcome. Again, it's not something which has been proven yet. And the ones that I've put at the bottom, the ones in this green color, these are still very much at the experimental stage. They're not available and haven't been proven yet. Metabolomics and Proteomics, so this is looking at the embryo media and looking at different metabolites, pyruvate, lactate, oxygen concentrations, things like that. We're trying to learn from them, different amino acids, proteomics. We're trying to learn from that more about the particular embryo and understand that, is this, what are the signs which show, what are the levels which show a good quality embryo from not such a good quality embryo, which would then hopefully tell us which embryo has the highest potential for achieving a pregnancy or for a live birth and reducing miscarriage. Again, this is not something which has been proven yet, but it's in development. It's not a new thing. I remember, 2010, this was mentioned. In 2008, actually, I think the first paper came out about this. But things have actually moved forward, and there are better techniques and more accurate techniques, but it's still not ready to be used. Another thing which is maybe more controversial and it would need a bit more of an ethical confirmation is genome editing, gene editing. There's something called CRISPR protocol, which is where you use a bacteria protein, which would then it's a defense mechanism of bacteria against bacteriophages, which could then be used to target certain genes on chromosomes to splice, to cut out the gene, and then hopefully that would allow in the future for where there is a genetic disease linked to a certain particular gene, you can remove that from the embryo to edit the embryo, and hopefully then change that embryo from an abnormal embryo to a healthy embryo. Because at the moment all we can do is test the embryo, and if it's abnormal we have to throw it away. And sometimes you only get a few embryos which are available for testing, which may mean that the couple go through a whole cycle and not have any embryo which is healthy, and then have to do a whole treatment again. Whereas if we can edit out the abnormal gene, this can mean you can change the embryo into a healthy embryo. Again, it's not something which can be used. When they have trialed it in China on human embryos, they used 3PN embryos, abnormally fertilized embryos. They found that this meant by editing the gene, you ended up destroying a whole chromosome or removing a whole part of the chromosome, leading to another completely new abnormality. So it may be something which another 5, 10, 15 years, who knows, can be helpful for certain couples, but certainly not available now. And then robots may be used as well. So just something which I think is quite interesting that has come out as a prototype. There's something called Natural Life by Overture. It's an embryologist in a box, they claim. There is a presentation you can see on this, which came out in 2019 by the company Overture. They're talking about this. It's a very exciting idea, where you put the sperm and the eggs within this box. This box will then sort out the sperm for you. So it will also remove the external cells from the egg. It will denude the egg and do conventional IVF. It will culture the embryo. It will do non-invasive embryo testing, so things like the metabolomics that we mentioned before. It will prepare the embryo for freezing. It can freeze the embryo. So all of this will happen within this one box. You don't have to move the embryo around or anything. You don't even need an embryologist. It will use all artificial intelligence and robots It's not ready yet. They came out with a prototype in 2019 and talked about it, but still haven't mentioned it again. So perhaps they're nowhere near having it ready, or maybe, who knows, they'll just come out one day and say it's ready to be used. We'll find out. And another type of, I don't know if you can qualify this as a robot, but Sperm Bot, they call it. So this is using a special helix, which is magnetized. It has nickel and iron. And this helix will then screw onto the tail of the sperm, and then they use external magnets to try and direct the sperm towards the egg or the ovaries. The hope is that this can be used to improve sperm, which when there's poor motility. So when we have poor sperm, at the moment we need to do ICSI, whereas perhaps with this we can do intrauterine insemination. We can inseminate the sperm, add these sperm bots, get these sperm bots to direct the sperm towards the actual ovary where the ovulation has happened. It's still very experimental. They've only used it on bovine, on cow sperm and eggs, and actually they've not had any success. Another potential treatment for this, or potential use for this, is in trying to direct chemotherapy. So for the gynecologists amongst the audience, this may interest you, that they may load the sperm up with chemotherapeutic agents and try and direct the chemotherapy towards the cervix or the uterine cavity, instead of injecting systemically, which causes all sorts of side effects and problems. So this is something which perhaps maybe in the future may be useful for these things, for fertility and also for cancer treatment. So risks and side effects of IVF, we've mentioned these already. Yeah, so I think if you've got any questions about what we've talked about, this is the time now. We can look through the questions that you've put up in the chat.
Excellent. Thank you very much indeed, Sami. That was an enlightening talk, and I can tell you we do have an awful lot of questions. So I don't know how many we'll get through in the next 10 minutes or so, but we'll give it a go. But we'll start off with Giant Meta. Thank you for your question, Giant. And they are asking about the relative incidences you gave of infertility from the outset. And obviously you've given us sort of fairly standard textbook one, but is it changing, and is the male contribution increasing? Because they're saying that they're seeing about 50% male these days.
So yes, I mean, there is an increase in abnormal sperm. We do know this. We're not sure why, and the numbers are changing. For the male, definitely we are getting more worried about this, and there needs to be a lot of research and to try and identify what exactly is going on that's making this problem. And it's certainly more prevalent in developed areas. So in the UK, for example, you find in big cities it's not quite the same as in the rural areas, and most countries it will be the same. So it's probably to do with lifestyle or diet or something like this. And yes, male is increasing, but also I've seen a lot of female increasing, and most of that is due to the age factor, like I mentioned earlier. It does vary from country to country, and in some countries, in the fertility clinics, you do see more younger patients than older. But certainly when I was in London, a lot of the patients coming in for private treatment would be older, partly because the treatment is so expensive. IVF is a very costly treatment, and younger patients don't always have the money if they don't qualify for government funding. But also because a lot of women are focusing on their career. They think that they can get pregnant at any age, and they turn up at the fertility clinic when they're 44 or 45. We used to see a lot of that, in fact.
So, so yes, male is increasing, but female is as well, and the balance is roughly the same in your experience. Is that fair?
Yes, but it may be different in different areas of the world. I don't know where they're working, and perhaps in their area they do see more male than female as possible.
Yeah. No, I answered that in the chat as well. So also from Giant, do you suggest AMH measurements before starting treatment?
Yes, I think it's good to get a complete picture as much as you can. So, all the bits of information that you can get will be helpful. AMH is a small part of the picture. It's not everything. AMH does vary. If you've ever done AMH within a few days, which has happened by mistake, sometimes you'll find that one AMH can be 6, the other one could be 8 or 9. So there can be quite a bit of variation, but it gives a vague indicator. And you can put it together with the FSH, LH, estradiol level, and the antral follicle. So you take all these three together to give you an understanding about this patient and how well they will respond. And it will help you decide the dose. Also, if the woman has had IVF treatments before, looking at those, how they've responded to the medication can also guide you as to what dose of medication you're going to use and what type.
Excellent. All the way from the University of Kent, this one. Hi, Alessia. Can you give us your opinion on reduction of caffeine and effects on fertility? What do you recommend to your patients?
Well, I mean, there is some evidence to show that high amounts of caffeine can influence both eggs and sperm and an IVF treatment. So there's even studies looked into IVF treatment. When I was at ARGC, we used to recommend for the patients actually not to take caffeine at all if they can. So we used to tell them not to take it. As a precaution, they can use decaffeinated products as an alternative, or herbal teas. And fertility patients, especially patients who are paying for the treatment, they are quite desperate and they won't have the best chance. So they will take your advice because they'll do any little thing that will improve the chance of them succeeding with their treatment. So yeah, we used to recommend to abstain if they can. But if they can't, at least minimize the amount of caffeine they take. I don't believe that if having a cup or two of coffee will make a huge difference, but I think the safest thing is to try and reduce it or abstain completely. Same with alcohol.
So we've got a number of questions from this person. I may be mispronouncing, but Uchechukwu, I think it's called. He or she is asking a number of questions, but I'll just pick one of them out. Can you reduce or prevent the incidence of either PCOS or OHSS during ovulation by your ovulation protocols?
So PCOS, you can't change the incidence. That's something which the patient will present with themselves. It is more common in some ethnicities than others, and we don't understand fully that. Probably there is a genetic element to it. But certainly if the patient has PCOS, then they are at higher risk of ovarian hyperstimulation. And you have to be very careful with this type of patient in how much you give them in terms of the stimulation drug, because yes, if you do give them too much, they will overstimulate. And you need to be monitoring probably more carefully with this type of patient than another. Yeah, it is something which you have to do as a clinician. It's your job, it's your duty to try and keep this patient safe. And if it does mean extra blood tests, extra scans, just to get that dosage right, then that's what you should do.
Excellent. So nice comment from Kiriaki here, saying a really great speech, really love it. And she wants to ask about the sperm bots. I'll jump in a second, Shadi. So even if it's successful, what happens to the helix? Does that dissolve? And if it's kicking around, doesn't it affect negatively the development of the embryo?
That's a very good question, actually. So yes, they say that they use nickel and iron and products which are not harmful to the body. They are minuscule. They are nano products. There's this nanoscience that we're talking about here. So there's not a huge amount of nickel or iron or whatever they use that's going to be in the body. And they say that they are using things which are safe for the body. We do know that people have implants which has a lot more of these metals in them, and they live with those for many years, and it's not been proven to be harmful to the patients.
Okay, Shadi, you want to jump in? I just wanted to say, I think this is Dr. Kiriaki, Sami, no?
Kiriaki, yeah, I remember. Yeah.
He's our colleague. He used to work in the ARGC, right, Sami?
Yeah.
There you go. So it's an old friend. Okay, we've got one from Agbor. Okay, here. Fantastic lecture, first of all, they say. But they say they have their worries about the robotics, particularly the embryologist in a box, and what would be the role of an embryologist thereafter. So I think they might be worried about being put out of a job. So what's your opinion on that?
I think it is scary for embryologists, to be honest, because if this does prove to be a very good treatment, then you may not need an embryologist, and somebody like myself could just set up a standalone clinic, just a room with a scan machine, have this box in the corner, and you could do one IVF every 5 days or 6 days without an embryologist. It is very experimental still, and it is scary. Yes, it's like science fiction, isn't it? Machines are taking over and creating babies. Yeah, the things that I mentioned at the bottom, they are very experimental. They may not ever come out, so don't be worried just yet if you're an embryologist.
Someone here asking for your phone number, but I'll maybe not broadcast that on the the chat here. So someone asking at what stage you do PGT. I'm assuming day 5 blastocyst. Is that right?
Yeah, I mean nowadays PGT really is done day 5 or 6 blastocyst, or sometimes day 7 really. In the past we used to do earlier. We used to do day 2 or 3, but there's something called mosaicism, where you're more likely to pick up a cell which is not representative of the chromosomes of the rest of the embryo. But with day 5 or 6, you can take a few cells and that will give a much better representation. You still can get mosaicism, but it's not as much as with the day 2 or 3, and the accuracy is also improved because you are getting more cells.
Again, one of my students all the way from Kent here, Vishankar, is asking, can you just explain for those who don't know the difference between agonist and antagonist?
I know I rushed through it a little bit because of the time. I mean, it's quite a big thing to talk about in a few minutes, so I'm sorry I may not have explained it so well. But in summary, agonist is something which would stimulate. So it's a generator agonist means it will stimulate the pituitary. And this is where people get confused because, yes, it does stimulate. Normally, naturally in physiology, this stimulation is pulsatile. So the hypothalamus is pulsatile method. This is what happens at puberty. So if you release it in constant form, which is the injection, which is given every day, or a long-acting injection, after a few days, this stimulation will come down and it will be suppression. And that suppression will continue for as long as you give that medication. Whereas the antagonist, immediately it blocks the receptor, immediately will have a suppression effect. Within a few hours, it works. So in summary, that's what it is. I mean, I can't really explain it so well in a few minutes, but maybe in another time we can do that in more detail.
Okay, last question then also from Vishankar. What's the effect of metformin on PCOS?
So if you look in more detail at PCOS, which again is another huge topic, one of the biggest things that we've realized is that they have insulin resistance. And insulin resistance, you may hear, this is a big thing. It affects the cardiovascular risk of long-term diabetes, but it also has a role to play in their hormone imbalance. And sometimes by giving this metformin, reducing the insulin resistance, even a woman can start to ovulate on her own without giving any other medication to stimulate. But also you can use it in conjunction with the clomiphene to improve the chance of responding to the stimulation. You can use it in conjunction with the IVF stimulation drugs or injections to stimulate the ovary. Some studies have shown it can reduce hyperstimulation as well. So it's quite a good drug. Some studies show that for PCOS it can reduce miscarriage rates. So it's quite a good drug to have as a tool. Sometimes we do find that it can be very helpful for patients.
Excellent, excellent. Well, ladies and gentlemen, thank you very much for joining us. We topped the 100 mark, which we're absolutely delighted to do. We seem to do that every single week, week in, week out. And it's partly as a result of our fantastic speakers, of which today was no exception. So, Sami, from the bottom of our hearts, thank you for joining us. Thank you for making time. Next week, we have the lovely Anastasia Mania, who is a good friend to both myself and to Shadi, all the way from King's Fertility in London, the United Kingdom. And she is going to tell us about setting up a PGT and genetics service in the IVF laboratory. So we're looking very much forward to that. I know that Shadi will want the last word, and I know he's got his little finger up at the moment. So I will pass him over to him for the last minute or so, and he's going to say something inspirational. Go for it.
Thank you, Professor Darren. Thank you, Dr. Sami. You are amazing. You always up with the technology in the IVF. I've been working with you for 8 years in the ARGC, so thank you for sharing this with everybody around the world. I just wanted, Professor Darren, just to announce from this platform that the IVF company and Kent University now officially have a training center in Dubai. It's in the Jumeirah Center, and it's not next to the Lamer Beach. It's the longest beach in Dubai. We will be operational hopefully within 6 to 8 weeks from today. So please, if you want to come for training and tourist week in Dubai, please knock the door, and we are very happy to organize all your trip to come. Soon the vaccine rollout will be done, and it will be very easy to come to Dubai. All yours, Professor. This is the only thing I want to say.
Oh, wow. You're being very, very muted today. That's it's very controlled of you, my friend, I have to say. So, ladies and gentlemen, it's been an absolute delight. Thank you for all attending. It's been great to hear from Sami. It will be great to hear from Anastasia again next week. Thank you for all your wonderful questions. I noticed that we had a number from Canterbury this time, which is always nice to hear. So thank you, Jan, for your question. Thank you, Kyriaki, for your question. It's been lovely speaking to you all. So this is the University of Kent signing off, the IVF company signing off, and we will see you this time next week for more IVF around the world. Thank you very much.
Thank you for having me.
Bye.